Hi everyone, in this video we'll be talking about the mood disorder bipolar disorder. Vincent van Gogh, a celebrated 19th century Dutch painter who has been called one of the most brilliant and influential artists in the history of Western art. As brilliant as he was, however, he was also very troubled. There are many theories about his mental health, assigning many different disorders to him. Among them, and most important to us, bipolar disorder. In his lifetime, Van Gogh suffered 9 reported depressive periods and 6 manic periods. Oh yeah, and also, he cut off his own ear. So what is bipolar disorder? It is an illness that causes unusual shifts in mood. Patients experience periods of depressed mood as well as periods of highly elevated moods, known as manic periods. The prevalence of the disease is 1% for the entire world's population. That is a really significant number of patients. We have 4 types in total. The first one is bipolar 1 disorder. It is defined by manic episodes that last at least 7 days or by manic symptoms that are so severe that the person needs immediate hospital care. Usually, depressive episodes occur as well, typically lasting at least 2 weeks. Bipolar 2 disorder is defined by depressed periods and hypomanic periods, which are less severe than the ones that define the first type. Cyclothymia is a form of bipolar disorder that can be defined by periods of hypomania and depression, which last for at least 2 years. Lastly, we have other specified and unspecified bipolar and related disorders. This is defined by bipolar disorder symptoms that do not match the first 3 categories. The exact mechanism underlying the disorder remains unclear, but several factors may be involved. Studies have shown that 60 to 80% of the risk for developing the disorder can be attributed to genetic influence. This indicates a strong hereditary component. However, twin studies have shown us that there's also definitely an environmental effect. And lastly, there is always the possibility of a change in brain structure because of neurological damage. Think of strokes, HIV, traumatic brain injury. Diagnosis is achieved through directed interviews with the patient and close relatives of the patient. However, diagnosis is often extremely difficult and on average only happens 5 to 10 years after onset of the disease. Before that, patients are often misdiagnosed with comorbid disorders like depression, schizophrenia, and anxiety disorder. So now that you know a little more about bipolar disorder, you might already suspect that living with it is quite the challenge. This is also shown in research. The disorder is associated with a significant impairment in the social, work, and family functioning, even during periods of clinical stability. That means people have problems, for example, in finding and maintaining employment and being in a stable relationship. Furthermore, patients have considerably increased risk for suicide compared to the general population, with mortality rates up to 15-fold higher. In the following, you will learn how exactly patients' functioning is affected. But first of all, let's freshen up your memory regarding emotions and behavior during manic versus depressed episodes. Typically, a manic phase is characterized by high energy, a reduced need for sleep, and feelings of euphoria, grandiosity, and impulsivity. During depressive episodes, on the other hand, patients usually suffer from low energy and motivation, as well as feelings of emptiness, sadness, and worthlessness. These episodes are often separated by euthymia, a relatively stable mood state, neither manic nor depressed. The intensity, duration, and frequency of these episodes vary from person to person and with the type of bipolar disorder. During both the symptomatic and remission phase, patients show deficits in social, cognitive domains such as theory of mind and emotion recognition. For example, impairments in the ability to understand other people's perspective. They also have problems with recognizing others' emotions, which is problematic since that skill is essential for an adequate social adjustment. On top of these problems in the social cognition, there seems to be a cognitive impairment that is present across all clinical states and developmental spectrums. These deficits correlate with illness severity and cause substantial impairments in psychosocial functioning. Even when they are in remission of mood symptoms, 60 to 80% fail to return to pre-morbid levels of psychosocial and occupational functioning. Deficits in executive functions are the most consistently found cognitive dysfunctions, and they are a very strong predictor of low psychosocial and occupational outcomes. Additionally, deficits in attention, particularly in sustained attention and memory, can compromise psychosocial functioning quite severely, for example, in school settings. Finally, cognitive flexibility is impaired, but is crucial for adaptive functioning, especially in novel situations such as having a new job. Especially in manic phases, patients can become hyperfocused and thus lose their adaptability and cognitive flexibility. Research have Research results have emphasized bipolar disorder as a progressive neurodegenerative disorder. There is a positive correlation between the number of bipolar episodes and the gray matter loss, and therefore cognitive loss. Generally, studies have failed to find a relationship between total brain volume and bipolar disorder. However, some studies point to an increase of the lateral ventricular volume, ranging from 5 to 86% compared to control subjects. Now let's have a look at the parts of the brain that play a really important role. In terms of cortical structures, there is a lack of evidence regarding a significant structural change in the frontal cortices of bipolar patients. However, a small number of studies point to a 10 to 40% decrease in the volume of left subgenual prefrontal cortex. In contrast, a hyperconnectivity between the medial prefrontal cortex and the ventrolateral prefrontal cortex has been linked to the dysfunctional emotion processing in bipolar patients. Moreover, findings indicate a decoupling of dorsolateral prefrontal cortex and the medial prefrontal cortex, which lead to poor attention, executive control, and working memory. Bipolar patients also show a decreased amount of gray matter in the cerebellum, as well as a volume decrease. Further investigation concluded that in bipolar patients with familial stress, cerebellar volume was even lower than in patients without a familial burden. Finally, the overall volume of the amygdala is significantly increased in bipolar patients. Interestingly, the varying functional connectivity between the medial prefrontal cortex and the amygdala seems to be evidence for the deficient emotion regulation in bipolar patients. Connectivity is heightened when viewing sad stimuli and reduced when viewing happy ones. Thank you all for watching. Until the next time, bye!